Hello, everyone. My name is James Hamet. I live in Boston, Massachusetts, United States, and it's a great privilege to join you today for the Digital Innovation in Mental Health Conference. I know that it's in London. I wish I could be there myself. I wish I could meet all of you in person. But times are changing, and that'll happen soon, I'm sure. So without further ado, thank you again for having me. My talk today is on reducing burnout for clinicians, as well as increasing engagement for clients. It's my belief that if we can achieve both, if we can both reduce burnout as well as increase engagement, that what this can lead to is basically treatment of more people, greater quality of treatment for more people, and also greater quality of life for our physicians and for our clinicians who, well, we really rely on. It makes me so sad to know that so many clinicians get burnt out and leave the field after only 3 years of work, for example, in the United States, where that's common. And so the topic for today around reducing burnout and increasing engagement is going to include some personal experiences of mine, as well as some tips and strategies on how to possibly achieve some of these results, and to share a little bit more about what I'm working on. So my background is in neurotechnology. I've built wheelchairs that people can control with their brain activity. This is using event-related potentials and electroencephalography to detect those event-related potentials. I've also worked to build a baseball cap that you can wear. It'll predict how mentally fatigued you are. And hopefully that type of technology can be used to prevent accidents on the highway as well as airline accidents. That project is waiting publication right now. And I'm also involved in dementia research as well with Alzheimer's specifically. But anyway, so through this experience and this exposure to neurotechnology, I built this interest in psychology, and that's really what led to this path of mental health, especially once I started working with mental fatigue and dementia. And so today, the most important thing that I'd like to highlight and bring to everyone's attention is that we all know that the quality of the encounter between the patient and the client, the patient and the clinician determines the outcome of care. When a patient connects with a doctor who they feel understands them, or when they connect with a doctor who they feel they can communicate very well with, this leads to greater health outcomes. And it's not anecdotal, right? There's a meta-analysis by Dr. Kelly Zolniak, where her team actually reviewed 106 correlational studies, 21 experimental interventions, and found that odds of, for example, treatment adherence were 62% higher with communication training for the clinician. And so in that case, right, what we're doing is we're creating value in that encounter, in the session. And so looking at current state of the art, right, we are trying to make that encounter as optimal as possible. We're taking notes, we're using different skills like active listening, but I think where there's a challenge in the field is what happens in between. What happens after the session and before the next session? There are many instances, right, where the patient will experience relapse. Many instances where the patient might fail to adhere with their treatment, and they might not even realize that it's happening until they talk to you and tell you, which they also might not do because, unfortunately, patients are dishonest narrators. Sometimes it could be an issue of pride, not wanting to disclose that they've failed something. But in most cases, it probably is innocent. I was doing a weight loss regime, for example, and I had a couple days that I had for cheat days. And, for example, if I gave myself 2 days out of the week to do cheat days, I actually wouldn't keep track of them. And the moment that I did, I realized that 2 was actually 4. And so that's just an example to show that when we're coming to these encounters, when we're coming to these sessions, there is a challenge of what happened in between, because the patient can sometimes come back worse off than the week prior or worse off than the month prior. And I know that, this isn't something new. You know this. And so in reading a paper it's an old one from 1989 by Dr. Sherry Kaplan. This was also a review, a meta-analysis for long-term chronic illness and patient clinician communication and how that was involved, how that was related. And what they found was that, you're heightening emotions in order to create better health outcomes. So a patient who shows up to a session, whether they're experiencing a lot of positive emotions or negative emotions, depending on how they're triggered, they're still leading to better health outcomes than if the session is a little bit more factual and less emotionally grounded. And they posited in that paper that it's because of the greater participation that the patient feels in that process when they really feel like connected to it because of the emotion that's attached to it. And so the question that I have for you guys today is, what can we do to bring those emotional encounters outside of the session? Is there a way to reduce relapse between sessions, maintain momentum between sessions, and grow engagement for the patient in their journey of recovery? And there are a couple strategies that, through interviews as well as through lit review, that have really risen to the top. Some strategies that I've noticed in private practice include emailing patients, texting patients, calling patients. In private practice, I guess I should refer to them as clients. It might be surprising or not, but these strategies are incredibly effective, and there's definitely a new body of work here to be done to measure the impact that this is having. Because at least, like, I'm running my own program right now, where what we're doing is we're actually messaging clients several times a day, several times a week, with the purpose of catching them at the right time, triggering the right behavior, dropping in the right emotions at the right time. And again, it's not actually necessarily about the right emotions at the right time. It's more about just like getting an emotional reaction and creating a sense of perceived presence. In dementia, simulated presence therapy is something that's sometimes used, where you'll use like audio of a loved one, a picture of a loved one, to decrease agitation, improve adherence, and basically improve the patient's sense of well-being, which, as you guys know, also has an impact on health. And so the idea here, the strategy here that I propose to the group, is to increase presence outside of the sessions. And how do you do that in a way that does not also increase burnout rate, that does not increase the workload? For many people who are working in the clinical space in mental health, I recognize that you might be bouncing from one patient to the next patient with really only maybe 5 minutes, 10 minutes to take notes, and to be prepared to be caught up to speed. You don't have time to be texting and emailing. So some strategies that can work are sharing notes with patients. You might want to take like a quick small subsection or a recap and share that with patients if you have time. Something else that can be helpful is collecting surveys from the patient throughout the week. There's a few simple strategies that you can do with like Google Forms, creating a form and emailing out. Obviously, I'm testing a method right now too, and this method is automating that process so that it all just happens for you. And it's your words talking to the client and to the patient. They get a text and it's written by you. But the thing is, you wrote it maybe a couple of weeks ago and it just gets sent out every second Tuesday, for example. And they can respond to it, right? And that really is the whole goal here with at least with this program, to get a response. And that's also the value of the recaps and the surveys that are commonly used, and which at least I recommend as well. if you can get the person to not just ingest the information, but react to it in some way, that would be a way to trigger them emotionally. Certainly, I remember some really cool papers that I've come across where the amygdala was damaged, and long story short, the patient had, reduced or totally not there emotional responses to things. And in these cases, those patients could not live in their day-to-day lives. They couldn't pick which foods to eat. They couldn't pick what clothes to wear. And they basically lived a life of paralysis. And what we can do here is by communicating with the client between sessions, we can create a presence, even if it's just perceived, right? Even if they get a text from you, and it's a text that you composed a long time ago, and it's maybe a text that they receive regularly, but just not regularly enough that they perceive, but they know that part. They feel like there's always someone there. They feel like there's always someone helping them, which creates an innate emotional response, which can improve the outcomes, right? Because now the emotions lead to choice, and really the choice that we're trying to alter here is the choice to heal, the choice to pursue our interventions and adhere to them, the choice to resist relapse. And so my thought to share with the group today and to close this talk is there must be many ways for us to increase perceived presence. If we can achieve improvement in perceived presence, particularly between sessions, then we can create momentum for the patients that will carry them through their journey, reduce relapse, and make it easier for you to see outcomes with patients. I believe that all of this together will reduce burnout, and I can't wait to see the other recorded talks that are available today, and connect with some of you to see how we can achieve this beautiful reality together, where patients feel like you are always there. Because the truth is, you don't have to be there. But if they feel that you're there, if they feel that you're listening to them, if they're engaging with their world, if they're open, if they're expectant, then that's a patient who is more likely to recover than a patient who's closed off, a patient who's pessimistic, a patient who is, feeling alone, right? We know that patients put in isolation, for example, tend not to live quite as long, regardless of what illness they're battling. Community really is important, and it's important not just for fun, but for health and for mental health too. And that's why I'm sure a lot of you, for example, you probably ask your patients to go and socialize, right? And to go outside, do a nature walk. The greater sense of community that we can build here, the greater the clinical outcomes will be. So thank you so much. That's my talk. Happy to connect with you, and have a great day.